session is on demonstration of advanced technologies in ultrasound. Here we'll going to demonstrate a live demonstration which will happen from our ultrasound room, and the same thing will be relayed here. So we're going to do two sessions. First, so for that, I'm going to invite our chairpersons for this session, Dr. Asif Momin. Sir, would like to come on? Or? Okay. Okay. So our chairperson for the sessions are Dr. Asif Momin. He's from Head Neck Cancer Institute, India, and Bhartiya Hospital, Mumbai. Dr. Saba Sheikh, she's consultant in ultrasound and ultrasound guided intervention in picture this and Sir H.N. Reliance Hospital. Dr. Yojana Nalavde, consulting radiologist at Nutan Mammography and Sonography Center. Dr. Anita Bajaj, senior consultant at Apollo Hospitals, Navi Mumbai. And Dr. Madan Mohan, he is a professor and head of Department of Radiology at D.Y. Patil Hospital and Research Center. So I would like you to invite our moderator and the demonstrator for the session. So our demonstrators are already there in the ultrasound room. Dr. Himangi, Dr. Rupa, can you hear us?
Can you hear us? Hello? Hello? Can you hear us?
Hello, hello. I thought some. Who's there? Dr. Rupa?
Purvi, can you hear me?
Yes,
Rupa
yes,
here.
we can hear you now. Yeah. Okay.
And I have the pleasure to introduce Dr. Richard Barr. You all know Dr. Richard Barr, and he's professor of radiology from Northeastern Ohio Medical University. And whatever I have and many of you must have learned on contrast or breast imaging, elastography for many years, and he continues to teach us great new things, and I'm really glad he's here. Thank you so much.
Since morning, she has been educating us further and further. I would like to introduce Dr. Rupa Ranganathan. She is a director and lead consultant in breast and women's imaging and interventions in the breast center at Kovai Medical Center and Hospital, Coimbatore, Tamil Nadu. She is a course director of FNB Breast since 2019, joint secretary of Breast Imaging Society of India, and a founder member and secretary of Society of Gynecological Imaging and Interventions.
A third person going to show us demonstration is Dr. Himangi Unde, Assistant Professor, Tata Memorial Center, and her areas of interest are breast and GI imaging.
I can hear you.
Okay, so hopefully this is going to work. Dr. Rupa is in another room with the patient, and she's going to be scanning the patient, and we'll be talking to each other as we go through. And we want to demonstrate all the new features that are available on ultrasound. So she will be using the supersonic machine that I talked about yesterday. And I thought we would just start with B-mode imaging. So like we said yesterday, that we have 3 breast probes that could be used on that system. There's an 18 linear, which is the workhorse. There's a 10 linear, actually, that for big breast, when we have the 3D probe, and we also have the hockey stick probe. So why don't we start with the 18, which is what we're usually going to start with. And let's see if we can see her scanning.
I'm starting the scan. She's a 33-year-old who had presented with multiple lumps in her right breast.
So just as she's getting started, so when we do breast ultrasound, we try to have the patient supine. I try to make the nipple pointing to the ceiling so that the breast is as flat as possible. And usually the medial portion of the breast we can do pretty well supine, but if the lesion is quite high in the axilla, we often have to roll the patient. And ideally we want to make sure that we have good contact all the way through, right? Because the breast is curved we want to try to position the breast. So usually, if we can move the patient so that area that we're looking at is flat, we're going to have better contact. And as she's scanning here, there's obviously a lesion that is hypoechoic and very irregular. And I think I have a pointer. Yeah.
So this is the largest lesion that she is palpating in her lower outer quadrant of her right breast. And this is very far from nipple, about 7 centimeter from the nipple. And as I move the probe closer, in 7 o'clock, I see similar masses, hypoechoic, irregular, and there are multiple as I move the probe close to the nipple. And all of them look suspicious.
Okay. So again, we've got the focus pretty much in the right area. And we've got now multiple masses, and we can turn on color. And again, we can see some color in the surrounding tissue. We don't see any within the mass itself. Here's another larger mass. So there's at least 3 masses that I see as she scans through. And again, we see a lot of color surrounding the lesion, maybe a little bit within the lesion.
Dr. Bhatt, do you want me to switch on the AngioPlus here?
Sure. So AngioPlus is a higher resolution, more sensitivity imaging for color Doppler. And now we're starting to see a little bit of blood flow in that lesion with the AngioPlus on. So here we can see, and again, what AngioPlus does, it allows us to see slower flow. So we will get more flow. We see these vessels a little bit better. And it allows us to look at the morphology of the vessels a little bit better.
I'm now switching over to the hockey stick probe because I see she also complains of a bloody nipple discharge.
So again, the hockey stick probe is a high-resolution linear probe, but it looks like a little hockey stick, and it allows you to go by the nipple, and you can angle and see things a lot better than you could with the big face linear probe. And you can see we're having
one
much
duct.
better resolution. Notice that the focus zone is now really focused in the first centimeter. And we can see, I believe this is probably going to be a duct. And we can see really well within that duct. There was a little bit of debris there. But you can maneuver around the duct, and you don't get very much artifact from the areola. So it's a very nice feature. We use it a lot, particularly in patients that have a discharge. We still do ductograms, but we would prefer not to have to do them. But this is another way of looking at the ducts in this area. And we can see, again, very high resolution. And you can see there's a little bit of a calcification in this duct. It's a little bit large, then it gets smaller, and then it gets a little bit bigger. And then I like to turn on color. Because if we can go to a nice place where you see that dilated duct, and we turn on color, obviously if we see blood flow within the duct, we're very worried that there's going to be something, and we can use this to guide. And again, here we can see there's some calcifications. We don't see any blood flow yet. We have AngioPlus on. We got a little bit of blood flow out here.
Actually, these ducts seem to get the communication with the smaller masses that we see closer to the nipple. And that's probably that's why she's getting a bloody nipple discharge here. So all these smaller masses look like they are intraductal, and you can see that this duct is finally communicating with these smaller masses close to the nipple. And you can see that one single prominent duct that goes up to the nipple. And you can see the discharge coming from actually clinically here over from this particular duct when I apply compression.
So again, having the ability to use several probes is very helpful. And I know they're very expensive, and you may not be able to, in your institution, have all of them. But if you can, they really can make a big difference in you making a diagnosis. So maybe we can now switch to the 3D probe and do just a 3D sweep over these lesions.
Yeah, we are in the 2D image of the 3D probe.
And then with the 3D probe, what she's going to do is she's going to center on one lesion and hold still, and then she's going to hit 3D. And the probe will do all the sweeping for you. So you don't do anything. Now that we see this mass a little bit better, there was a lot of calcifications, and you can see extremely rapidly we now have our 3 planes. This is the plane that she was scanning in. This is the 90 degrees, so this is axial, this is sagittal, and this is the coronal. So it's actually going from the nipple to the chest wall. So a lot of surgeons like this, we call it the surgeon's view, because it's like them looking at the patient, and they can get a better feel for where they're going to do their operation. And a lot of times we can see a lot of the architectural distortion a little bit better on the coronal view than we can on the axial or sagittal views. And again, here we can see the mass. She's doing another sweep, and again, you'll notice, 5 years ago, we had to do this. It took us forever, and we didn't like to do it, but this is obviously extremely fast. And maybe what you can do is you can go now and do the slices and show them how we can actually do a bunch of slices through this. So again, here what we're doing is you'll notice that we are taking CT axial planes. We can pick whichever plane we want, any of the 3 planes, and it will now slice that volume into axial, and we can do up to 16 slices. We can make it smaller. We can change the size of the slice. And again, this is kind of nice because, so in the U.S., I don't scan every patient. We have sonographers. If I have a new sonographer and I don't know how good she is, she can do this, and now I made sure that she's covered everything. And these can be sent to the PACS, and they can be done as a cine clip. So we can see this as a cine clip. We can turn on here. She's turned on the color to highlight features. But again, you can change the slice thickness. You can change the spacing between them. You can pick whichever slice, axial, sagittal, or coronal plane you want. And again, here it's nice to see, because we have several masses, we can kind of see them in that 3D volume. The 3D volume is also very nice. And again, here we're really close to the skin, and maybe there may be a little bit of involvement. And again, that would be an area that maybe using that hockey stick probe, which is really centered to be in that first centimeter, to get a better view. Where the 18, again, now we're centered down more, 2 to 3 centimeters in the breast. And again, when we save this volume, we can go, and we're not going to show you here, but we could have actually taken each slice. We could have outlined each slice, got the volume for each slice. We could have added them up, and we would have had the volume of the tumor. So this is very useful, because if you're doing neoadjuvant chemotherapy, you know the tumor doesn't shrink nice and uniformly. It shrinks very weird. So it's very hard to 2D to actually know how much change there is. But here we can do the whole volume, and we can follow the volume over time. And now, again, we knew this 10 years ago, but it would take us a day to do it. And now it's very fast and very rapid. And again, we can do this in color. So if maybe you want to turn on the color, and we could do a 3D sweep with the color.
Can we move on to elasto now?
No, I was going to say, why don't you do a 3D color?
There is no 3D color. We have a 3D elasto in this, not a 3D color.
Ah, I thought there was 3D color. Okay, let's go ahead and go to the elasto. So again, we do elasto on every lesion in our institution, except if it's a really simple cyst. Although I will tell you, we've seen several cases that my partners thought were simple cysts, but when you turn on color, there's blood flow and they're stiff, and there are triple negative cancers. So you have to be very, very careful. And although people say it's a simple cyst, I'm always worried that we're going to miss that triple negative cancer. So I always insist that they at least turn on color, if not elastography. And again, here we can see this is another view that you get both color as well as elastography with one button push. You see them both. Obviously now in this area, we're seeing a lot of abundant blood flow in this lesion, and it's very stiff. And if we look at the color map, I'm going to say that it was probably at least 120, if not 140, so very indicative of a cancer. And if she holds still on it, so this cancer, actually the whole thing colors. There are some areas that look like they're a little bit soft, but again, that's probably artifact. And sometimes these areas that are very, very stiff, the shear waves just don't go through them. They just bounce off, and you may get this lower color. So this does not mean it's a necrotic tumor. It just means these areas are stiff. And again, we look for the highest area, and we put on our ROI. And again, I like to look at the max, 258. The mean is taking all of the pixels and averaging all of those pixels. So if you change the size of the ROI, you're going to get a different mean, but you'll still have the same max. So that's why I like to use the max. And again, notice that she's on a different area. And again, this area is a little bit stiffer, and that we're not getting good shear waves through it. But a lot of people call this the ring of fire. So it flags to us that this is a cancer. And the other thing we can do is, again, when she's off to the side, we may not see much, or sometimes we may not see that ring of fire. Like here, we're not seeing it very much, but in other areas of that lesion, we see it. So this is where, again, 3D is very helpful, because we have areas that are artifacts and areas that aren't. So if we do 3D, we can see the stiffness all around the lesion. And while she's getting set up there, so there are other things that, I like to mention that I drive my sonographers crazy about. If you feel a mass, but you can't find it on B mode, turn on elastography, because you will find something. You can guide your needle for a biopsy with elastography on, and that helps us a lot in lesions where there's a palpable mass and we just don't see anything on B mode. The other thing that I found out, and we haven't written it up, is this system always has harmonics on. Some systems don't have harmonics on, and a lot of people don't like harmonics because you get shadowing. But the reason you get shadowing from harmonics is there's something there. Even though you don't see it, there's something there. So if you turn on elastography, you'll notice that there's a very stiff mass there, and in general, it's either an invasive lobular cancer, or it could be mastitis, the inflammation from mastitis. And then it allows you to see where the mass is into a biopsy. So this really helps us in picking up those invasive lobular cancers that on B mode, and maybe even with color, we couldn't pick up. So again, we did our 3D. And again, we can sweep through it, but notice that we can see the stiffness value all around it. And if you were here yesterday, I showed you that there are several studies now that show we can use the stiffness to predict if neoadjuvant chemotherapy is working. So again, if you do it in 2D, it's very hard to know you're in the right place. But if you do 3D, you can clearly see the stiffness value around the lesion, and it's usually very dramatic, that over the course of the chemotherapy, all these red things are going to turn blue. So you can tell that you've got a very good response. If the colors stay about the same, then you're not getting a response. So again, having the 3D is really helpful to make sure that you're looking at a global view of the lesion. And again, we can slice and dice however you want. And again, you can notice how fast you can do these things, which really saves a lot of time. Now, you don't want to send the 3D volume set to your PACS, because it's huge, and your PACS administrator is going to kill you because you're going to use up all his PACS space. But what you can do is, there's a USB port. You can get a USB stick, and you can download all these 3D volumes, and then if you want, you could bring them back up and do it. So that way you're not saving. If you have a lot of patients with neoadjuvant chemotherapy, you're going to fill up the hard drive. You can send this back, and then you can pull it back up again. I think if you have a DICOM reader somewhere, you could actually probably do a lot of this stuff on a workstation. And again, you can see we can find the area with the highest stiffness, and then we can put a cursor on there.
Dr. But can I demonstrate it in the hockey stick probe now?
Sure,
The elasto,
yes.
yeah.
So again, notice that the focus is in that first 1 centimeter. So this is really focused to look at very close things, things that are close to the skin. And again, here this one is very close, and you can see we can pick out all these calcifications. And again, all the breast probes do elastography. And again, you'll notice that this lesion is not red, but there's red around it. So this is telling me that this is very, very stiff. So it's probably a high-grade cancer. And if you would have looked very closely, you would have noticed that actually that this cancer looks like it's softer than fat, which is not possible. So that's another clue to you that this is a problem and this is not a benign lesion. So just beware of that. And I think that we're bugging the supersonic engineers to try to fix that problem, and hopefully that'll be fixed. And I think that's been one of the problems, that people don't understand that. And in fact, I've had engineers say, well, it's soft, it's necrotic. But I'm saying, I'm trying to stick a needle in it. I can't push the needle in it. The needle's bending. It's so hard. So again, be aware of that. And like I said, a lot of times it actually shows up as being softer than fat, which is not possible. And again, we find this hockey stick probe really good for looking at ducts, looking around the nipple, and looking at ducts, and any lesion like an epidermoid or sebaceous cyst. We see a lot of those. It gets us a little bit better view than using the 18 linear. And now she's back to the 18 linear. So do we want to look in the axilla to see if there's any lymph nodes?
This lady also has got an internal mammary lymph node which is involved. By the man. This is, I'm scanning at 9 o'clock position.
Yeah, so she's finding things everywhere.
You can see that this is internal mammary lymph node with basic vascularity, but this looks like it's been involved by the tumor.
So this actually creates
Moving to the axilla.
okay. So this creates a problem because now we've got several lesions in different quadrants. Are you going to biopsy all of them? Do you biopsy one of them and assume all the rest are going to be cancers because they look like BI-RADS 5s? What do you do? If there's two lesions, we usually biopsy both because oftentimes they're different cancers. And the oncologist needs to know that. But in this case, there's so many lesions. What do you do? Do you do an MR just to see how globally things are? This person probably will get chemotherapy, but they're going to want a diagnosis. So again, we kind of rely on the oncologist to tell us, do you want us, how many of these you want us to biopsy? Obviously, they all look like cancers. If they do chemotherapy and they all have a good response, great. I would suspect that this person would eventually end up with a mastectomy no matter what goes on. And again, now we're looking, here's a look like a somewhat normal lymph node, and then another, I don't know if it's the same lymph node or a different lymph node that's obviously
They are all different lymph
metastatic.
nodes.
It's a different lymph node. So again, I actually do core biopsies of the lymph nodes if I can. Our pathologists like that. If we can do that, obviously if it's in a place that's surrounded by vessels or problems, I would do an FNA. But I try to do cores as much as possible because I think that the pathologist really likes that and it helps them a lot. The other thing that I showed a case, for those of you that weren't here yesterday, if you have lymphoma in the breast, it's soft. So be aware if you have a patient with lymphoma and you have a well-circumscribed, very hypo, vascular lesion, don't believe elastography, because if it's a lymphoma, it's going to be soft. However, if it's looking at lymph nodes that are abnormal, they're usually going to be very stiff, okay? So if we see a mass, a patient lymphoma, we see a breast mass, but it's very stiff, I'm sure it's going to be a breast cancer, not lymphoma. And do we want to do a shear wave of that lymph node?
Yeah, I'll do that. You want the shear wave on the internal mammary or the axillary?
The axillary, I think.
Axillary.
And again, sometimes they show up as being very soft, but obviously this is an abnormal lymph node, and obviously we would biopsy it. But again, if you look, it's very soft. And again, I wonder if this is so stiff from a very high-grade cancer that that's why we're not getting good shear waves.
Do you
Now-
want me to lower down the elastoscale?
Yes, and as I said, if you have a lesion that looks soft, we can color. So she's now dropped the scale from 180 to 95. It lets us see visually the differences between the shear waves. If we have that high scale, the colors may not show up if they're very close to each other, but you can drop down the scale and you can now see where areas are stiffer than others. Now, the other thing I would do, and I don't remember how to do it on this machine, is to do a panoramic view. Because you've got so many masses, if you're really good at scanning, you can try to line up all the masses. Because what's really important is what is the difference in size between the two lesions? Because that's going to help the surgeon figure out what is he going to do. Is he going to do one big lumpectomy or does he need to do two? So that's another feature that I think is really helpful that we always do to give them an idea. And again, obviously, if the person went to an MR, we would be able to do that a little bit better. And sometimes we'll see if Rupa's a really good scanner and she can get them all lined up.
No, it's in the different plane, so.
Yeah,
let me
sometimes
give
it's
it
hard.
another try.
Sometimes it takes I actually put a little marks on where they are, and then I can follow that when I do the transducer. But again, I think that's helpful to do that panoramic view, measure the distance between the lesions. It gives the surgeon some idea how are you going to approach this. Obviously, in this patient that has so many lesions that it's somewhat difficult to do. But again, once she saves this, we can actually measure. She doesn't have two of the lesions on this frame, but and the image is somewhat blown up here and a little bit and not as nice as I would see it on the monitor. Let's see how she does this time. And like I said, I often will put a mark where I see the lesions and then I know how to track to follow. So here's one. So she had three. So I think we went over all these features again, picking the right probe, picking the right preset. Okay, we have a preset for easy breast, hard breast. So if you pick the easy breast, it's telling you that it's a small breast and it's not very stiff. You're going to get better resolution, but not a lot of penetration. If you pick a difficult breast, you're going to lower the frequency of the transducer. You're going to be able to see deeper, but you're going to lose some resolution. And there's no reason why you can't do a higher resolution in the near field and lower resolution in the far field. So don't be afraid to change that as you go doing the exam. So is there anything else, Rupa, you want to show us?
No, I think we had seen all the lesions notes.
Okay, and I think we're nearing running out of time. So does anyone have any questions?
I just have one small question or comment. If there is no hockey stick, do you use the standoff pads, or
Yeah.
do you recommend that in the areolar region?
Right, and so again, it depends on the transducer. And actually with this 18.2, if you go to a easy breast, it moves everything up. So you may not need to use the standoff pad. Okay? If you're using the 10.4, for sure you probably will need the standoff pad.
And do you have a separate scale for the nodal analysis as far as the elastography goes?
I don't, and we can do elastography of the lymph nodes, but in my experience, on beam mode, they're all abnormal.
Right.
So doing elastography, I've picked up one or two that have a smaller macroscopic focus because there's a one stiff area on the lymph node. But for the most part, almost all of the lymph nodes are already abnormal on B mode. So we're not picking up additional abnormal lymph nodes.
Any question, anyone?
So I believe the system is going to be around somewhere. And I think that Mindy will set it up so that if you guys want to practice on it or look at the machine, it's available for you guys to do later today or tomorrow.
Sure.
Is that correct?
Thank you, Dr. Barr.
Thank you. Thank you to Dr. Barr,
Okay.
and thank you, Dr. Ranganathan. Thank you for the excellent demo.
All right, so I think we can have the lights up, and we'll wait for Rupa to run up here and move on with the sessions.
So we can start off with, it's a pleasure to introduce Dr. Mukta Mahajan again. She's a lead consultant breast radiology at Apollo Proton Cancer Center in Chennai, lead consultant interventional radiologist, and she has fellowships in breast imaging from University of Vienna, Austria and Ottawa, and many publications and areas of interest introduce multimodality breast imaging, neoadjuvant therapy, treatment response, assessment, vacuum-assisted intervention, high-risk screening, and interventional oncology, oncoimaging. Welcome, Dr. Mukta.
Thank you so much. Okay, so this is going to be a joint demonstration by me and Dr. Teja Logle, who's a resident in TMH. We are going to talk about automated breast ultrasound. Dr. Barr just showed us how panoramic view helps us in getting all the lesions together. And we're now going to draw your attention to something further than a panoramic view, and a global view of breast through ultrasound. And how that can, what is the technique, how does it look? It does give a special feature, which is a coronal view of the breast. Using a modality that all of us use extensively, we depend on it heavily. Also it helps us in looking at spatial orientation of different lesions within the breast. So why ultrasound? Because we know the problems of high density and how it obscures small masses as well as distortions. We know that as the density increases, the mammo sensitivity to detect cancer decreases. At the same time, the ultrasound starts performing better and keeps a reasonable sensitivity in heterogeneous as well as extremely dense breasts. So the automated breast ultrasound, it's very self-explanatory. Automated meaning the image acquisition is decoupled from image interpretation. The acquisition can be performed when the radiologist is not at site with the patient, and the interpretation happens at workstation, which is dedicated for automated breast ultrasound with dedicated software. We have used there's clinical role in screening, and it shows acceptable recall rate and sensitivity while maintaining improved cancer detection rates for clinically important cancers. There are a few barriers to implementation because it requires additional training, the additional cost of the device, and also challenges about integration of the workstation into the pre-existing packs. But what we know is that it improves the scan times. The patient on table is there for much lesser time because you're not now hovering over the lesions trying to analyze or characterize it, but you're just scanning them. And once the scans are finished, the patient moves out of the room and makes space for the next patient to come in, while the interpretation happens after by the radiologist at the workstation. So the workflow improvements are real, and we'll just go over that shortly. It has also been assessed in diagnostic workup setting, whether it has any role in breast cancer staging. We'll come to that at the end. So as I've mentioned already, it's a modality that all of us are aware of, all of us are familiar with. It's just a different way of looking at ultrasound breast, a global view, a coronal view, and which is performed in an automated manner, which means that it's not operator dependent anymore. The images are reproducible, and it also provides an important solution for some of the main drawbacks that the traditional handheld ultrasound has, which is the lack of standardization, which requires high level of skill, and also which it unfortunately gives us a small field of view, and it consumes quite a bit of radiologist's time. So now these are the two main automated systems. One is a prone system, the other one's a supine system. Supine system is what we're going to talk about and demonstrate. There are several vendors. The important parts of this is how the workstation view looks like for a prone system. And this is for the supine system. So these are the demonstrated coronal images of the breast, and the bottom row is the acquisition image in axial. So an automated scanner has three parts. It is composed of a scan box. So this is a scan box. It has obviously a transducer, which is here. The arrow is pointing towards the transducer, which has a complementary reverse curve to fit the breast shape perfectly. Earlier generation machines used to come with a flat contact. However, we've seen that the reverse curve obviously is doing a much better job, and which is of length of 15.5 centimeter to help us give us a big view, global view of the breast. The third component of the scanner is a thin membrane, which is under the scan box, which makes it very easy for the probe to glide over the breast in a single sweep. So the transducer plate obviously has a very big footprint, and it also gives you a very wide field of view along multiple angles, whereas the handheld is straight down, but here you have the benefit of looking at things with multiple projection angles. Now I'm going to request the screens to change to the demonstration room, where Dr. Tejal is going to be show us how acquisition of automated breast ultrasound is done on a patient. Can we change the view, please? Tejal, are you able to hear me?
Yes, ma'am.
Great.
So should I start?
Are you ready at this point?
Yes, ma'am, I am.
Can't hear you very well. Can we increase the audio input from the demonstration room?
Ma'am, no need. We are changing the mic position.
Much better.
Ma'am, can I start?
Yes, please. Please go ahead. The screen hasn't changed though yet. So you're going to see two views, the patient view as well as the monitor, the acquisition monitor of the automated breast ultrasound.
Ma'am, have the screen changed?
No, not yet. Yeah. So we can see the acquisition monitor at this time.
On the right, we have the patient.
No, not yet. No, only a single screen is seen. Yes. Okay, please go ahead, Tejal.
Okay. Thank you, ma'am. So here we can see on the right of the screen, the patient is positioned supine uh, with her ipsilateral arm raised overhead with flexion at the level of elbow. The head is rotated contralaterally and the breast is lying flat with the nipple pointing upwards. For difficult cases, you could just use a rolled over towel underneath the shoulder to acquire the desired position.
So as you can see, the breast is positioned in a manner so that the nipple is at the summit, and you have eliminated any folds or creases on the sides. The arm is in an overhead abduction position. She's spreading the gel over the entire breast so that there's smooth contact.
For a standardized acquisition, we have three views: the AP view, lateral view, and a medial view. For a AP view, we need to place the inferior border of the scan box along the inferior mammary fold. So this would help us cover the whole of the breast in the AP acquisition. So if you could see on the right, we have a direct relay of the machine. Where in the center, you could see there's a nipple areolar complex, and it will also adjust the depth of acquisition depending upon the size of the breast. So here we have depth of acquisition of 5 centimeter, which seems to be adequate. We are now going to see if I'm able to acquire whole of the breast in anterior-posterior acquisition. I am comfortable with the position and the contact which I could see on my end. I'll start the acquisition. I am applying some manual pressure so that the breast tissue lies flat. In case if I need any assistance, there is an assisted compression mode which I would use. If you could see on the bottom right part of the screen on your left, there is a small dome-shaped thing. Once if I compress, it just goes down. It will just give the idea of compression given there. Once I'm comfortable, I'll start the acquisition. Now the probe, which was at the level of nipple areolar complex, will move quadrily. And the image acquisition has not yet started. So once it has reached the caudal leg, and it will move in a caudocranial direction, and the image acquisition would start. So as the probe is moving cranially, I'll tilt my scan box according to the contour of the breast so that I'm having adequate contact and no compression artifacts or contact artifacts. So here I have the entire AP acquisition, where the yellow blink dot is the nipple marker. I place the nipple marker.
Great, so single acquisition is complete and she has marked the nipple so that the machine identifies the orientation.
So since I'm adequately satisfied with my anterior-posterior acquisition with no contact artifacts, I'll move on to the lateral acquisition. For the lateral acquisition, I want my lateral line to lie along the mid-axillary line. At times, it is difficult to have adequate contact. In such cases, I'll ask the patient to roll slightly so that I have adequate contact between the foot now I have asked her to roll it over slightly and I have adequate contact. As mentioned, the lateral border along the mid-axillary line. I would proceed with my acquisition.
So the acquisition time for each projection is about 35 to 45 seconds. If you do 3 standard acquisitions for a breast, it's going to be about 2.5 to 3 minutes for each breast. As you've seen that for the first 2 acquisitions, the frontal as well as the lateral one, you didn't have to change the patient position. In the same patient position, you could do 2 acquisitions, and depending on the breast size, for the medial breast, you may want to then remove the lateral wedge and make the breast fall straighter on the chest wall. You can take additional views as well at this point in case some part of the breast has not been included. So this is the lateral projection where you can see the nipple has moved more medially and you have acquired the lateral aspect, inferolateral aspect, superolateral aspect quite adequately. There's a good contact, no artifacts. So once the image is acquired, the technologist or the person who's acquiring the images is going to screen it for artifacts. If there are any, then the image can be repeated at the same time.
Ma'am?
Yeah.
Yeah. So here in the lateral acquisition, we could see around periareolar 10 to 11 o'clock, we could see a hypoechoic lesion on the coronal plane. Few in this slide, you could see few others.
Yeah. So here the resolution is not focused. The image is optimized at all depths, whether it's just under the skin or at the chest wall, the entire depth is optimized for resolution. And now the last one. It's important to have adequate amount of gel to improve the contact, especially if there's a scar on the skin or there's a depression, and also in the axillary regions. So as you can see that the image here is not appearing on the lateral aspect because there's poor contact. However, that part of the breast has been already covered in the earlier acquisitions so that we are not missing any information. So we've completed 3 views for the right breast, and we started at 4 and it's 4:11 right now. So in 11 minutes we've finished along with the explanation, so it will be much shorter when you're doing it without the live demonstration. So even if you take 10 minutes for one breast, we are still covering a scan in less than 20 minutes for both sides. And this is a predictable time. So when you have a long list of patients who are waiting after screening to get to come to a supplementary ultrasound, a predictable time can be spent with each patient with predictable appointments and a better workflow, which is not dependent on what the radiologist is doing. So now there are additional views as well, but Tejal, can we move back to the presentation?
Yes, ma'am. Yes,
Great.
ma'am.
Thank you so much. Thanks a lot. So these are some of the additional, so the standard views are 3 for each breast. There are additional acquisitions as well, depending on how the patient habitus is. We'll see some of the images. So this is how the workstation view looks like. You have the acquisition in axial plane, which is how we see the breast through a handheld ultrasound, and this is a coronal view, which is new, but it's something that, you know, if once you're used to looking at and examining, the spatial orientation of the abnormalities within the breast becomes very easy. So this is a case of biopsy-proven invasive ductal carcinoma. You can see it in the mammogram. This is the mass, and you can start seeing it here within the breast in relationship to the position of the nipple, and you can see crosshairs on top in the coronal view, which are, but once you identify the lesion in the axial view, you can start seeing them in the coronal view as well. So when you're looking at, when you're analyzing or interpreting the images, you're going to see the axial images as well as coronal. It's important that we go through all the axial images so that there are no misses in coronal. This is another example, irregular mass, this is a handheld ultrasound with a small field of view. This is a long field of view, which is the ABUS with a mass, and it can be seen, and we already know that it's close to the nipple. Depending on what slice it is on the coronal view, you can also depict whether this is a superficial one or deep one. So the kind of information you get from single view is going to be the clock position, the distance from the nipple, the depth from the skin. It also tells you if there are associated features such as architectural distortion, which actually is seen much better on coronal view than on axial view. So you can see the spiculated mass in coronal view here. At another depth, you can, in the contralateral breast, you can also appreciate a small mass which has irregular margins seen beautifully in this left breast. These are the speculations and distortions that I'm talking about. You don't appreciate the speculations as well on an axial view, but in a global image, it's on coronal view, it's seen very well, similar to how we see it on mammogram. Again, 2 examples, 2 different lesions, irregular mass, suspicious for sure, in the upper outer quadrant of the right breast. This is a circumscribed oval mass, which is again seen well on the coronal view. We already know the clockwork position, and it's also superficial to the skin. So the sizes we don't have to manually measure, waste time measuring multiple lesions, and if there are multiplicity of lesions in breast, adds significant time if you're measuring them live. So all this can be done at a later time point during image interpretation. This is an example where there are multiple lesions within the same breast, and all of them are suspicious. We can see at least 3 of them in a line over here. The beauty of the coronal view also is that you can change the orientation of crosshairs and line them up in a single radial plane so as to understand the distance between these masses and also from the nipple. So as we've seen the image acquisition, we realize that there are few issues with the contact with the breast. So if you don't make sure that, if you don't see a good contact of the transducer with the breast, there's going to be loss of information. There are some additional artifacts, and we'll go over some of them here. So this is the nipple artifact. Now, the image quality depends on how pliable the nipple is to ultrasound and to the probe. If there is posterior shadowing, which we can come over by tilting the probe on a handheld ultrasound, unfortunately we can't always achieve that on an automated breast ultrasound. So this is one important artifact, nipple artifact, which can be reduced when you're doing the lateral plane or a medial plane, where the waves are passing by the side of the nipple, and we are able to see the subareolar region much better. However, sometimes you may have to call back a patient if you want to see the immediate subareolar region slightly better, particularly using hockey stick as we just saw in the prior presentation. Now, this is an artifact called as the attenuation area. If the breast is high, the breast parenchyma is very dense and it's highly attenuating to the sound waves, you can see dark areas with lost information because of the shadowing. So this is not fat. So fat is gray. When you see black on a coronal, that means there's no sound passing through. It's the posterior artifact. This one over here, which is pointed out in the acquisition plane, again, there's loss of information because of poor contact, and which is what we are seeing in the inner aspect of the breast. Now, these spots or the posterior areas of posterior shadowing are because of the air bubbles which are trapped between the transducer and the skin, and this is what we need to look for during the acquisition. And the technologists can be trained to, whenever they see this, they have to apply generous amounts of gel and rescan the patient so as to not miss any information behind the air artifacts. This is an interesting one, which is typical for a probe that moves the glides over the breast, where if there's a mass which causes a bulge onto the skin, while the probe is gliding over the edge of the mass, there's going to be a sudden skip artifact, which is that you can see on coronal view, it looks like a straight line. And this is because transducer has jumped over from the edge of a firm mass to a softer breast, which is following after. So it's one of the important artifacts called as a skip artifact. We need to be aware of it so as to avoid any misinterpretation. I'm going to play this video. The white wall sign is, you can see multiple cysts, and posterior to the cysts, as the coronal view is moving towards the chest wall, you can see the areas of posterior acoustic enhancement, which appears like white walls. So it's just because it's a new view to look at the breast, it's just something that one gets used to fairly fast. So the advantages are, as we've seen, that it's reproducible. Comparisons are possible because we have the volume data with us. The entire disease extent can be planned on the coronal view, and it's also easy for the surgeon to visualize it in space. It also improves the lesion detection and analysis using the coronal plane, where you can see the ancillary features such as the architectural distortion, which is definitely a high gives a high positive predictive value for malignancy. With the increasing experience in ABBS, we've seen that the recall rates do reduce, and then the dependence on the second look ultrasound reduces. So this is an example for a patient who's come for a screening and has undergone an automated breast ultrasound. We see an abnormality on the coronal view. The axial view shows the, something that sort of a dilated duct with content, hypoechoic content within. The patient was called back for a handheld ultrasound. Now, we do recognize that we don't have the liberty to use color or elastography with automated ultrasound, but whenever a finding like this pops up, you can always call the patient back and reassess. Now, we know that at this time point, if you're worried about a solid component within a duct, whether you see flow or you don't see flow, your next step is going to be dependent on patient's symptom, the size of the abnormality, and whether you need a biopsy or no biopsy. The color Doppler is not going to make a huge difference. So this patient may be called back for a follow-up if it's not very big, or if it's small but she's symptomatic, then you're definitely going to biopsy whether you can show color or not. Now, this area was biopsied. This turned out to be ductictasia. So from management point of view, please remember that you'll be calling far fewer patients with your precious time being spent at the image acquisition. Now, this is a case of left breast lump, which was excised 6 years back, and you can see the scars as well beautifully on the first slice, which is at the level of the dermis. Again, smaller lesions can be seen really well. As I told you before, the resolution is adjusted to the entire depth of 5 centimeters, and so you can see the areas beneath the skin, the glandular tissue, as well as the pectoralis muscles and beyond pretty well. This is again, on the left you can see ABUS and the handheld ultrasound image on the right. This is a global image, but you are still able to identify that there's a small scar or a linear communicating area of hypoechoic content. And when you call the patient back, we are looking at only a targeted view of this area. But it does pick the abnormality, and then depending on the history, we can decide whether this patient needs to come back or not. Again, a case of right breast that's showing irregular high density mass with lobulated margins. I'm going to play the video of the coronal acquisition for you. Yeah, so the nipple marker stays in place, so you know the clockwise position. The distance, the size can be easily measured. This is the acquisition axial view. And so here you can, if you move the crosshairs along the radial plane, you can see that there is linear extension, probably representing intraductal extension. And along that line, there are some additional masses which are also seen, which could represent multifocal disease. The handheld ultrasound also provides you the same information, however, it takes more time and it's only giving you a short field of view. So perhaps it has role in staging as well, and we need to explore more. Few more examples of multifocal breast cancers. So now we do identify that there are limitations, such as ulcerative lesions over the breast, post-breast cancer and axillary clearance changes. We are not really evaluating axilla at this time point. Probably we can see level 1 nodes, but nothing beyond. Post-radiotherapy changes when it becomes, the breast has inflammatory changes, the skin has inflammatory changes, the glide of the transducer becomes a little bit of a challenge. Lesions such as this will be hard to scan through an automated ultrasound. However, these are not the patients we are looking at as an indication for automated ultrasound. Scars can pose problem, but I think we can have some innovative solutions of having small, large amount of gel, or have a special view for such areas to improve the contact. This is again an example of how a lump which is protruding over the skin can result in poor contact, resulting in suboptimal images, but there are possibly ways of overcoming that, and we are exploring it. So the disadvantages, we know that certain artifacts, once you're aware of it, your technologists are trained for it. It is a bit of a learning curve, but you get over that. The image-guided procedures cannot obviously be simultaneously planned, and the patient needs to be recalled if additional handheld imaging, diagnostic imaging needs to be done, or if you need color Doppler assessment of axilla and simultaneous invasive procedures. So what you're looking at when you're staging a breast cancer, you're getting information only about the breast and possibly level 1. You won't be able to provide simultaneous information about the nodal stages, definitely not the nodes which are higher up in the apex of axilla or retropectoral regions. So in terms of clinical application, it has been studied in the symptomatic breast clinic as well. It is still under evaluation. However, some of the data shows us that the meta-analysis, which involved almost 1,500 lesions, there was a higher pooled sensitivity and specificity for ABVS in lesion detection compared to ultrasound. So it is able to detect more lesions for sure. The inter-observer variability, there are multiple studies that have heterogeneous results. However, a large study which involves 1,800 patients has shown very high inter-observer agreement. You're looking at the same standardized volumetric data. It also becomes comparable for BI-RADS3 lesions when they come back. There's also significant improvement in the cancer detection rate and a strong correlation between the ABUS and HH ultrasound, that is handheld ultrasound. Local staging could be one of the additional applications, monitoring response for neoadjuvant therapy, as well as second look ultrasound after MR. It can also be used to follow up benign lesions, which I just mentioned. So in summary, it is an old modality, but a new technique, and it has a unique feature of looking at it through a coronal view. However, it does require adequate training, and there's a learning curve. It is efficient, it's reproducible, and it also poses itself as a supplemental screening, supplemental modality for screening, which does not take up radiologist time. So there are developments in computer-aided detection as well, and which can further improve the sensitivity and specificity, and also perhaps reduce the reader time. Thank you for your attention. Any questions? So the vendor that we demonstrated right now is the GE unit, but we also have Siemens unit that had come in almost a decade ago. That I would not know.
I have been using ABVS for almost
Yes.
a decade, Siemens user,
Yes.
and I actually end up doing a handheld after the ABVS editing. And it does take, despite the training,
Yes.
it does take a lot of time to interpret.
Sure. So
And of course, compromised Doppler, compromised elastography, evaluation of retroareolar location, and algorithm. These are all the component of our testing.
uh,
This is my
this is important feedback.
from a person who is using.
Absolutely. So we had this. I had the privilege of using this in 2012 in Jaslok when the Siemens, ABVS had come. We in fact presented our data of 100 cases as well. What is important to know is that I think probably we are not using it in the correct setting, because the idea is to screen when there is. Yes, so it has a robust application in screening where you want to look at, when you know that there's a drawback of summation artifact where there's too much tissue come together, and then we know when we see an ultrasound sweep that does not show a focal lesion is good enough for us to move ahead. So this is for screening the extremely dense breast. In our setting, which is for diagnostic work, and if it's taking your time to use the ABVS to acquire the images, you're obviously not going to like it. So if you don't have,
For the resident sitting at the back,
Yes.
that handheld is the gold standard, would be the gold
Absolutely.
standard in our country system.
yeah, so we are probably looking at settings where there is high volume screening.
Long way to go for India. So ABVS it is a research tool yet, and with its limitations.
So now we do have this machine now in Tata, and maybe we'll hear more data from India coming up, and I think we should watch out for that. Thank you. Thanks.
Actually, we have a good sonography expansion everywhere. It is easily available, as well as the many radiologists are well trained in ultrasonography. That is a plus point. So that is why the handheld, it's very useful in our country, because many patients are complained with the large masses, and even then these are not very useful. It is mostly in the screening setup, and screening in India it's not very very useful, and because we are not convincing the patients here, especially in the underprivileged, to go for the screening. So that is the one more drawback here.
Our population has larger breasts.
Larger?
And larger breasts, larger cup-sized breasts, and in that, taking only standard AP medial and lateral views doesn't help. You have to end up taking extra views, which takes up your time as a radiologist. You have to guide the technologist to take those views as well. So we
these are-
have to add on not only the acquisition, the interpretation by
Time as well.
the radiologist as well for these extra views.
So these are all great inputs for Tejal, who's going to be studying it in the weeks and months to come, but all points well taken. This is, I think the maximum benefit is when the radiologist's time is not used while acquiring the images. Rest of that in a diagnostic setting is still under evaluation.
How much is the cost effective in that?
You have to speak to the people behind. maybe
And
after this
for
session.
per investigation charges, how much it's at?
Again, beyond scope of what I can answer.
Then the MRI is better option.
So we are also, you have to also remember that we are in a country where thermography is taking over screening, where, there is elastography, which says that, we do just as good job, we do a very good job, better than a mammogram. This is a valid tool, modality, which we know how to interpret, we know what it can tell and what it cannot tell. So clinical application is something in our setting that needs further exploration, no doubt. But yeah, I think the process has begun. Thank you.
Yeah, thank you so much, Mukta and Tejal. Before Dr. Nitin comes here, just 1 minute of thanks, especially to Buildtech Solutions. They had offered the wireless solution for the live relay that we've just seen. So we did not have to lay down all those cables. So, having AI used even in our audiovisual relay, and they've just helped us support with this process. Thank you so much.